So, in case you don't know where we're from, we're at the Royal Bournemouth Hospitals in the UK, which is still part of the European Union at the moment. We're the south of England there, right on the coast. Oh, I'm having trouble. Okay. So we're a general hospital. We're a 900-bedded hospital. But we're also the regional cardiac centre. So we do a lot of cardiac CT, a lot of cardiac MR. There's 12 cardiologists. There's 3 cardiac radiologists, of which I'm one. And it's a big centre. We do 3,000 PCIs per year. So, I'm just going to talk a bit about the technological advances in CT. So what are the major technological advances in CT over the past few years? Well, one of the main things is that the detectors, particularly on the high-end machines, have got much, much more efficient. The iterative reconstruction techniques have got better and more efficient. Really big difference, and it's available on a couple of the vendors now, is wide area detector technology, which means you can cover the whole heart in one rotation, which has got a lot of advantages, which I'll talk about later. And all of the above things for cardiac CT produce much better images using much lower doses of radiation and a lot less contrast as well. So lower doses of contrast and radiation. So, people say radiation dose, I don't really care about that doesn't really matter. Well, there's an interesting paper that was out last year in JACC Imaging, where they basically looked at a whole bunch of people that had cardiac CTs. So these are all within the normal diagnostic range. And they looked at whether any of these patients had DNA damage. And then basically, if you have more than 7.5 millisieverts radiation, then you could get detectable DNA damage, and that DNA damage increased as the radiation dose increased. Now, that doesn't prove that that's bad. Maybe there's repair mechanisms. Maybe those people don't come to any harm. But if it was me, I'd rather not have my DNA damaged. Now, interestingly, if you were less than 7.5 millisieverts, you couldn't get, with any test that you could do, you could get no DNA damage whatsoever. So this would kind of imply that there may be a threshold of about 7.5 millisieverts. If you can get less than that routinely, you're probably not causing much harm with cardiac CT. Of course, this is only one study, but it's interesting. So, if we take 7.5 millisieverts as a level that we're trying to aim below, we try not to damage our DNA, how do the centres in the UK measure up to that? There was a survey a couple of years ago now where we looked at all the radiation doses in the country and for cardiac CT. So this is across the UK, and I think the striking thing is how low the radiation doses are generally, pretty much on all the centres. Now, there are a few outliers there, but the red line there is 7.5 millisieverts. So this is the medium radiation dose. So actually, most centres in the UK are way under 7.5 millisieverts mean. And the green arrow there is our radiation doses, which were around about 1 millisievert. That's for all comers. So 1 millisievert is pretty low as a mean. So why were our radiation doses so low? It's not just that we're brilliant at it. I mean, obviously we are brilliant at it, but that's not the main. It's the technology, really. It's the main thing. So detector technology. There have been huge advances, certainly on the high-end systems, in detector technology over the last 2 years. So basically, the detectors now are much, much more efficient in picking up the photons. Because in the past, essentially, there were photons that were either being absorbed by the patient that were not necessary and were not contributing to the image. That was causing dose. And also, the detectors themselves weren't picking up all of those photons. So there's been big changes in that. So you get better images at lower dose with the new detectors. This is Toshiba's new detector, which we have on our high-end machine. It's 40% more efficient, essentially, theoretically, than the detector that it replaced. Now, that sounds like in the real world, it's never going to be 40%. But interestingly, this is actually a clinical study that we did. We looked at a whole bunch of patients scanned on the old machine and the new machine, both the Toshiba Aquilion 1, so both identical, but just had a different detector. And actually, our doses, with changing nothing else, went down by 40%. So image quality was the same, noise was the same, but like you're not getting now, this was a free lunch. So we got 40% less dose. So the detectors help a lot, reducing the dose. There's the other new thing is that iterative reconstruction is a new thing, and it's getting much better. And first of all, what it is, it's a different way of transforming raw CT data into an image. So you filter back projection. This is a traditional technique. This is the new way of doing it, which interestingly was the original way of doing it that Godfrey Hounsfield used, but it just took too long. And it's basically a fundamentally different way of generating an image, and it's got potential to dramatically reduce the radiation dose because it's much better at dealing with noise, it's much better at dealing with imperfections in the system. Toshiba's latest mainstream iterative reconstruction is called ADA3D Enhanced. I won't claim to understand it, but basically it's much more clever in the way that it generates the image, and it can adjust for all the imperfections of the system, essentially, whereas filter back projection works great when you've got quite high radiation doses, but at very low radiation doses, filter back projection doesn't work so well. This works much better. Just a clinical image, it shows how low you can push things. This is you'll forgive me for some thoracic images here, but you're mostly radiologists, so I'm sure you look at these as well. This is a 35-year-old woman, IV drug abuser, needle in the left main bronchus, and DLP 6 for the whole study. You see the needle there. The story was she'd run out of all the veins in her arms and her legs, so she was injecting heroin into her tongue, and the needle came off and she inhaled it. So this was removed bronchoscopically. This is Toshiba's, my mic's gone. It wasn't that bad, was it? This is Toshiba's latest iterative reconstruction technique called FIRST, which is a true model-based system where there's no filter back projection at all, and it shows that you can get doses incredibly low of DLPs of 5.07 millisieverts, and this is a really obese patient. So this is a chest X-ray dose from a CT scan. Can you still hear me? Or has my mic gone completely? Yeah? Okay. So this just shows in normal clinical practice how much the radiation doses have come down with all the new technology. Patient scanned in 2006 with a DLP of 226, which is 3.8 millisieverts. Scanned again recently, DLP of 6, so 0.1 millisievert. Same patient, virtually the same image, but 38 times dose reduction. So huge reduction. So, talked a bit about the detector technology, talked about the iterative reconstruction. I'm now going to talk about why it's a benefit to have a wide area detector. Well, basically, if you've got a wide area detector on CT, it enables you to have coverage of a whole organ, in this case the heart, in a single gantry rotation. And that's got a lot of advantages, particularly in cardiac scanning. This just shows the coverage here. Basically, our detector, Toshiba Aquilium 1 detector, is 320 times 0.5, so it's 16 centimeters, so that's enough to cover pretty much anyone's heart. We don't always use the whole detector width, actually. We often use less than that, but you can go up to that, so that pretty much covers everyone. GE have the same coverage on their Evolution, but they have less resolution. They have 0.625 millimeter detectors instead, but the same coverage. So it's the same idea. And because you get isophasic images, we sort of take that for granted as well. Not only do you get no step artifact, but because everything is at the same point of time, it makes image interpretation a lot easier. This is just a PDA, and this is all acquired at one point in time, and you can see the contrast coming out of the aorta, coming into the pulmonary artery, and it's held by the pulmonary valve there, all acquired at one point in time, and much easier to see because it's isophasic. So, with our wide area detector, what's our typical protocol? It's pretty straightforward. It needs to be because we scan very fast. Basically, the patient lies on the table. We give sublingual nitrates. We give IV beta blockers. We give 60 mils of IV contrast usually. We get images of the heart and coronary arteries in one breath hold and one heartbeat. And the whole process takes less than 10 minutes. It's a very simple scanning process. The scanner always goes around once. We always acquire either end diastole or a slightly wider radiation pulse if their heart rate is faster. So it's very easy for the radiographers, and we can get very high throughput with that. So this is what on a conventional spiral system, this is what we used to get in 2003. That's when we started cardiac CT. And we used to give about 20 to 30 millisieverts, and this is an image typical image, sadly, of the LAD, where you can't really see it's the LAD. And this is what we get now in 2016. This isn't the best image we get, this is just an average image we get, and this is about half a millisievert now. So it's a massive step forward. Of course, the technology has changed massively in that time as well. And interestingly, if you look at MR technology over that time, there's really been a lot less change. So CT has just changed dramatically over that time. So scanning all cardiac patients at these ultra-low doses, so what? But the so what is the fact that we can use it much, much more widely. We don't have to worry about young patients anymore. We don't have to worry quite so much about the indications anymore, because I'm sure in the centres you work, your indications are all fantastic, but they're certainly not in ours. But we don't worry so much because the radiation doses are much lower. And the radiation doses are so low now that we can use CT instead of MRI to exclude aberrant coronaries and, in fact, all sorts of other structural things in young patients. So we often use CT as a first-line test in young people now, which sounds horrible in the days of 20 millisieverts, but in the days of 0.5 millisieverts, I think it's fine. It's just some typical cases. 26-year-old woman, the question was chest pain on exertion, has she got aberrant coronaries? The answer is no, and we could do that at 0.17 millisieverts. So that's pretty much the dose of an AP and lateral chest X-ray. I mean, people say, well, you can't possibly do a CT in that person, but the patient's already had an AP and lateral chest X-ray, which is in fact the same dose. So we just do this now. 17-year-old man, chest pain and syncope on exertion. Basically, every time he did exercise, he used to collapse. And he was getting very convincing, reproducible chest pain on exertion. And he had an aberrant left main stem arising from his right coronary. And we can do all of that at about 0.2 to 0.3 millisieverts, so the sort of chest X-ray doses. We used to do these on MR. We're using navigator sequences taking 20 minutes. Now we do it on CT. It takes about 2 minutes. And in slightly older patients, basically you can exclude coronary artery disease at sub-millisievert doses. So this is a 35-year-old woman, still young, much younger than me, with atypical chest pain, given 40 mils of contrast, got normal coronaries, 0.3 millisieverts dose. So again, it's a very good rule-out, as you've heard earlier. CT is a very good rule-out test, but now we can rule these patients out at extremely low radiation doses. So a 40-year-old woman had a treadmill test, which is no longer recommended under British NICE guidelines. Treadmill test was negative, i.e. it didn't have any ECG changes. Actually, she did have chest pain, but it was put down as a negative exercise test. She got a critical left main stenosis. And again, this is at about 0.5 millisievert. So the other thing about wide area detector, with wide area detector single heartbeat CT, it's much, much quicker than conventional CT. The scanning process is just much simpler for the radiographers. There's only two options. It goes around once, either with a wide radiation pulse or a short radiation pulse. And you do that with all heart rhythms, including AF. So it kind of just always works. This is the sort of images we get in AF. This is someone who's going for left atrial planning. We can get images of the left atrium and pulmonary veins. We used to do this on MR, but now we do it on CT at basically a chest X-ray dose, 0.1 millisieverts. So we don't scan any of these on MR anymore. And we can also exclude left atrial appendage thrombus with 100% negative predictive value as well on these scans. So they don't have to have transesophageal echo anymore. This is someone, average-sized patient with dyspnea, got Becker's muscular dystrophy. The question is, have they got coronary artery disease? They weren't sure about their ejection fraction, so we didn't give any beta blockers. Single heartbeat, wide radiation pulse. The heart rate, acquisition heart rate, was 105 beats a minute, and the total dose is 1.7 millisieverts. And apart from a bit of calcium there in the LAD, there's virtually nothing going on in this patient. They haven't got any obstructive coronary artery disease. But what they have got, and perhaps this should have been known before they sent it to us possibly, is they've got an ejection fraction of 7. So you get functional images for free using a wide radiation pulse, and this is still 1.5 millisieverts, and we've got the answer. And this is just an aside really, but we're now starting to produce really quite nice images in patients with stents. Not always. If you've got very thick stent structure, they're stainless steel, they're not so good. But in most stents now, we're actually getting some pretty nice images. And this is a fairly typical image of a stent. And this is using all the fancy technology. You get really a very clear image of the stent. Well, actually, you're not getting a very clear image of the stent because all you can see is the light. But I'm getting a clear image. And the new development of CT is stent subtraction, where basically you've got a stent there in the LAD, and then you can actually remove it. You'll hear a bit more about that later in a later talk. But actually, it's a very nice technique. You do a pre and a post contrast, and you subtract one from the other. And basically, now the radiation doses are so low that you can exclude PE and aortic dissection all at sub-millisievert. So it's a kind of triple rule out we can do at sub-millisievert. So basically, if you've got the best technology and you've got the right protocols, radiation dose really isn't an issue really in cardiothoracic CT. I don't think we need to worry about the radiation dose anymore. We need to really worry about what we use it for now. So the radiation dose isn't a problem, but what about contrast? Okay? Because contrast dose is still an issue. It's associated with contrast-induced nephropathy, and higher contrast doses are associated with more contrast-induced nephropathy. So if you've got a powerful tube and you've got a very efficient detector, you can use low kVp scanning in a much, much wider range of patients. And if you use low kVp scanning enables you to use lower doses of contrast. And the reason that is because of the K-edge of iodine. Basically, if you reduce the energy of the photons, they are absorbed more strongly by the iodine because of the K-edge, and you get in brighter contrast. So you can use that effect to reduce the volume of contrast that you use. So basically, low kVp scanning is really not a radiation dose saver in my view. It's actually, for the same image quality, it's a contrast dose saver. And this just gives you an example. Different patients scanned at different kVps, but you can drop the contrast dose right down and you still get the same enhancement because you've dropped the kVp. And these are just some routine clinical cases. This is patient scanned at 80 kVp with only 30 mils of contrast, and you get 547 Hounsfield units of enhancement in the right pulmonary artery, which is very adequate. This is, again, an ablation study, someone with dodgy renal function, 30 mils of contrast, only 3 mils a second because they had a poor cannula, and it's 0.16 millisieverts dose, and it's only 30 mils of contrast. So, and you can see an occluded left inferior pulmonary vein there as a result of a previous ablation. So the radiation doses are very low, contrast doses are very low. So why don't we use cardiac CT as first line for all patients with suspected coronary artery disease? Well, it's funny that I mentioned that because the new NICE guidelines, we heard about the NICE guidelines earlier, they're the current NICE guidelines. The NICE guidelines are just about to change, i.e. within the next couple of weeks. Now, I admit I've only seen the draft so far, so I'm slightly ahead of myself here, but this is what I predict the new NICE guidelines will be. It's pretty likely. So basically, risk stratification will no longer be there. CT coronary angiography will be recommended as first-line investigation for all cases of suspected coronary artery disease in patients with chronic stable chest pain. And functional testing, calcium scoring has gone completely. Functional testing is no longer recommended either, and catheter angiography isn't even recommended because they're all second-line investigations. So what's the likely impact of these new NICE guidelines is that CT coronary angiography will move from a niche test, which it still is. I mean, I know everyone here in the room probably does it, but it's still a bit of a niche test in a lot of places. It's not that commonly done in some places, and it will become very much a mainstream test. It will become the main test to look at coronary arteries. And I predict, certainly in the UK, that an average large general hospital with about 800 beds will be doing more than 3,000 cardiac CTs a year. So pretty big numbers, and much bigger than most people are doing at the moment. And all but the smallest hospitals will have justification for low-dose, high-throughput cardiac optimized machine. I don't think, if you're doing that numbers, I think you probably want the best kit with the highest throughput. You know, they spend a fortune on catheter machines, so I think you might as well get the best, because you'll be much more efficient and you'll get your money back. And now the catch with all this is that all radiologists, not just the people here, are going to have to do cardiac CT, which will cause, that will be an enormous requirements for training, and probably an enormous requirements for scanners, which will be good for the vendors, obviously. But it will be major, major changes for all of us. And I thank you for your time. And I won't take questions now, because I think we're going to take questions at the end.